Okay, there we go. Sorry for the slow delay. Welcome to your 5 days of a good review. For those of you who do not know me, I am Dr. Lian, and I'm here to review this wonderful examination with you. I know you've been very patient, and we've had some good news that they are slowly organizing themselves. So give them time, okay? It may seem like you're buried, maybe you've been planted, so be still and wait for the rain. So let me get on to business today. I will give you a question during the break, and maybe the first two people who can get it right will be able to give me will be able to do a mock with me today. So let me just make sure that everything is good. Now, as you study for the Plab, I actually did a little bit of review, and I said, as part of this review, I have to talk to you about this Plab blueprint. For you to be where you are now working for the Plab 2 exam, of course, you've passed the Plab 1. So this is not an exam of theory, okay? They are actually trying to help you prepare for this exam. And I was going through the Plab blueprint, and I said, goodness, look at all these wonderful cases that are not only tested in the Plab, but are tested in PACES. Some of them come up in MRCS examinations, and even in the OSCEs for the medical students, and for, sometimes they send the FY2s to, for some clinical examinations. But it is all in the blueprint. So we are not succeeding in this exam because we are lacking knowledge. Okay, so it's actually the guide that they're giving you with your theoretical cases. All these cases can be changed to be clinical cases. So now those who are complaining, there are almost 1,000 cases in the Plab exam, we don't know what to study, where to study from. The foundation program curriculum, honestly, get some time to just log on to this website and see. It really gives a step-by-step information of what to expect as a second-year doctor in the UK. Okay, so they are really trying to help us to prepare for this exam. All the topics and skills needed to pass are covered in the blueprint. So abandon all these recalls, abandon all these little notes people are giving you, this is how the exam looks like, this and this and this. No, if I have time, and now if you go to their Facebook page, they've said that the exam is going to resume August 13, and then they'll start opening it up again in September. If you have time, invest again, scrap everything and start again. Start studying for this thing. Now, when you find out what resources they are giving you, it's all listed. There's a good medical practice, okay? You have courses. So they actually say you do not need to attend a study or coaching course to pass. It's not a hard exam. Okay, and those of you who are maybe in my sessions, my little training sessions, I hope that during the 3 months of going through some common cases in clinical practice, I hope you are able to understand that this is an exam at a foundation year level. If you know the boundaries of your practice, it will be easy for you to succeed. Okay, many candidates choose to do so. Of course, if you've been out of clinical practice for a while, or if you've not had a chance to use mannequins, by all means. But don't waste too much time studying for these things. 6 months, 8 months. When I do people's scorecard reviews, they tell me they took out a year to come to the UK, stay in a hotel, work, maybe, not of course work, but work on this exam for a year. It really is really not that feasible. It doesn't make sense to me. I say maximum amount of practice for this exam. When you start. If you're balancing family, job, and all this, then give yourself at least a 3-month period. But if you have organized all these other activities of life, then give yourself a month of hardcore practice. at least 4 hours a day, 2 in the morning, 2 in the afternoon. And that practice should not be passive. It should not just be you reading, the foundation program, book. No, you have to practice with someone. And you're in such a big group with the WhatsApp groups, more than 200 people. Find somebody, please, please, please. I was actually going through this Plab blueprint, and I wanted just to discuss a couple of cases, just in overview. Today's introduction to the review. So I'm going to talk a lot, and then tomorrow we'll fine tune a few more things. Diabetes is a very important disease in this country, type 1 and type 2. All right. Now, if you have a patient who's coming in with complications, you want to make sure you address the immediate complications first, especially eyesight. Anybody who is coming to you past medical history, they've been a diabetic for 12 years, you're trying to shake their hand, they're missing your hand, their focus is off, so they're talking to you like, this doctor, I've been having diabetes for 12 years. Wouldn't you want to comment? James Smith, 65, we are in a room together and I'm talking to you, but your gaze is off. When you were shaking my hand, you seemed not to see where my hand is. Are you having problems with your eyesight? For how long? Why would you sit down with somebody for a good 8 to 10 minutes asking them questions and they have eyesight problems? You have to alert someone. Even in acute cases of vision loss, this is an emergency. Don't spend your first 2 minutes trying to ask them about their occupation, whether they are driving, trying to give them all this counseling. Get the help, okay? And people are getting disqualified because of management. They're not showing that they know how to deal with acute situations. A pregnant woman sitting in front of you, and we'll discuss some OBGYN cases, maybe day 3, day 4. A pregnant woman who is sitting in front of you and she's holding her head and she's saying that she's feeling dizzy. What do you want to do for her? My goodness, you better put her down, check her vital signs. Ask very pertinent questions. Is the baby moving? Is the baby kicking? All right, have you had any injuries at all? What could this headache be about? I want to know a blood pressure within the first 30 seconds, okay? If she can, let's do a urine dipstick. Woman 36 weeks pregnant, 37 weeks pregnant, is having blood vision, headache, okay? You're asking about the baby moving barely, and there you are asking about her occupation and whether she took the red bus to work today. Please do vital signs on these people. And in the capacity of an FY2, you should call that OBGYN specialist to get there as soon as possible. You even want to say, maybe, can we get an ultrasound here? The child may need a CTG. If it's preeclampsia and you're wasting valuable time, that baby is going to be in danger. And then you don't want that to be on your hands, okay? Diabetic foot care, hypoglycemia, hyperglycemia, patients with diabetes undergoing surgery, diabetes in pregnancy, all this is on the blueprint. So again, those who are busy whispering there are 600 cases, now I'm saying there are 1,000, 2,000 cases. Beautiful scenarios that can just be created from this blueprint, okay? So if you have time, at least just go through the blueprint. If you have no access to it, tell me, I'll send you a PDF copy, because some of you are out of the country and maybe don't have access to it. I'll mail it to you. You're on my mailing list, yeah? Here, including acute abdomen of any cause. Somebody coming to you and they're having pain in their abdomen, okay? You want to think of acute causes of abdominal pain, obstruction, ischemia. Could it be an aneurysm? Is it kidney stone? Okay, and what are your actions towards it? Because even sepsis can present in this manner. So what is my direction with these statements? If the patient is unstable, don't waste time. You need to check your vital signs. Okay, look at all these other things. A man can come into the GP clinic. James Smith, he's 28 years old. Doctor, I have a bit of a concerning issue. I'm noticing that I'm developing breast tissue. Okay, has this case been tested? Maybe not. Okay, so many different things. So even as you go through this blueprint, just look at the types of management that you can offer. What would you tell James if he's coming in and he's presenting with enlarged breast tissue? First, you have to realize it's embarrassing. Okay, so you want to tell him, all right, there are many causes. Don't be alarmed about this. There are many causes, okay, and some of them, in fact, most of them are usually reversible. When did you start noticing this? When was the onset? Is it one breast tissue or is it both of them? Okay, have you noticed this for the last 2 months, 3 months, a couple of days? Was there any injury to the chest area at all? Are you noticing any rashes? Does it hurt at all? And then you cannot just ask you have to understand the questions that we ask really have to be very sensitive. You just don't want to ask the guy, are you noticing that milk being produced by your breast? You're going to make him run out of that office. Milk? You know, and I'm actually giving you these scenarios because when I do my mocks, I really try and throw the doctor off, because a robot, if you throw them off, they don't have balance. They'll topple over. So I really catch people and I call them, you're being robotic. You know, how do you just come in and just ask, have you noticed that you're having any problems with your eyes? Are you noticing that there's any milk being produced? No. You know, sometimes when our patients notice the development of extra tissue around the breast area, see how different and how good that sounds? They sometimes have vision problems. Are you having any vision problems? No, I'm not. Are you noticing that you're having any discharge from the nipple area? Okay. Any white discharge? No. And if you notice that he's being, why are you asking me that question? You have to kind of follow up with, you know, almost an apology. I'm sorry if that seemed a bit off, or it seemed a bit rude. There are different conditions that are related to the development of extra breast tissue, including the use of some medications. You know, some medications have steroid components. Instead of just asking him, do you take steroids? No, okay, you want to be very savvy when you're talking about sensitive conditions. And then, of course, gynecomastia in a male, what do you want to do? Even though he's saying he's not having blood vision or vision problems, you are the doctor at the gate. So your investigations have to cover diseases from different systems so that you can know who to refer to, okay? If he's having complaints of headache, vision changes, of course you will send him to the direction of neurology. So do you want to do a vision exam? Yes. Do you want to see the chest area to do an examination? Yes. So you don't have to wait for the question to tell you do an examination. You want to include it in your statements. At some point, I would like to do the following things just to rule out these conditions. Sometimes it's because of, you know, an abnormal growth of cells in some areas of the brain, okay, that affect vision and maybe cause an imbalance of hormones. I need to check your prolactin levels. You know, I can talk to one of the seniors or one of the specialists who are here. You cannot just say you're going to now, goodness, what did somebody tell me? We may have to now go in and check and see if you have a mass in your brain. But don't worry, we can give you medications for this mass. There's one called bromocriptine. It's going to shrink the tumor. You do not even know that the patient has a prolactinoma or not, and you've already advanced yourself from FY2 to SPR, senior registrar, to consultant, and now you are the neurosurgeon, telling me they can go through a sphenoid approach to get it. Stop. That is not safe medicine, okay? Somebody can come to you just from the blueprint. I have such a good time making new cases. I think I have almost 40 of them. Just going to this blueprint and just saying, let me develop new cases for this Plab. Yeah. Impotence. I'm having a hard time, you know, me and my wife, we've been married for the last 10 years. Doctor, we don't have any children. do you understand what that does to a family? A man and a woman, and you know, bless them for not going the easy way and thinking of different spouses and abandoning their marriage. You know, bless them for sticking it out in a marriage for 10 years and they don't have children. Bless this man for coming in to see a doctor to say, I'm having a hard time getting children. You want to get to his heart. You know, I'm sorry. How long have you been trying? We've been married 10 years. You know, and I don't know if it's a problem with me. I don't know if it's a problem with my wife. There are so many things that can cause impotence. And now if a patient asks you, what do you think is going on? They're not asking for a specific answer. And the worst thing you can say is, if a patient asks you what is going on, I'm going to refer you. Why did they come and see you in the first place? Can you give them a bit of knowledge? Yeah. And when I'm asked by a patient, what do you think is going on? I always start broad. And for those of you who've taken the course, I know some of you are just jumping in today. You have not seen you since we started. You're welcome. Don't worry. I got you covered. Okay. Where is all this? Where can impotence come from? Okay. It can come from him. It can come from his wife. Okay. It can come from a family history. So you want to find out, and don't just go and ask him, have you ever had a sperm count? Not every man goes for these things, okay? You want to at least start from a broad view, okay? Do you have any medical conditions? You know, are you taking any medications? Because some medications can alter, you know, some of your testosterone levels. Some medications can cause impotence. Some medications can cause, is it impotence because of anatomical problems, okay? Or is it physiological, or is it psychological? So this case can go, it can just bloom, okay? He could be nervous, okay? He's nervous because, you know, of certain stressors. Or maybe when he gets home, he's too tired, you know, to love his wife. Who knows? Okay, he could have a problem of undescended testes, cryptorchidism that has not been recognized for 35 years. Bad doctor, why didn't they notice that in the GP's clinic? It could be with the wife. How old is your wife? How and has she also gone for testing? Are you using any birth control? Has your wife been on birth control for the last 5 years? Do you see where I'm going? So that now when you're in a station in front of a patient, you are thinking concerns, you're thinking coping, and you're thinking differentials, different reasons. And when you are being warned that you only have 2 minutes left, if you're being warned that you have 5 minutes left, depending on the exam that you're taking, they're trying to help you to wrap it up. So some of these cases are so beautiful, but you have to stop gathering the data and continue on with management. Okay, let me just keep this moving. Now, psychological and social cases. So non-accidental injury is important for you to know. When an elderly person is coming in, actually not even just elderly, children, people who are dependent or disabled, pretty much everybody. There is a sixth sense that we have all been gifted with. Somebody is sitting in front of you and telling you that I fell down the stairs. One of the questions, of course, on top of vision problems, leg problems, proper lighting. So you're thinking environmental causes, is it lifestyle? Were they intoxicated? You want to find out the condition of the home. Whenever you're doing a family history, let it not just be anybody in your family with the same medical conditions. Falling down the stairs, medical condition. You know, everybody in your family who has had problems with fractures. No, whenever I do my family history, I always start with a question. So, who do you live with? I live with my husband and my 2 children. Okay, how are they doing? How is their health? How is the environment at home? Okay, would you say it's peaceful? any recent conflicts. Then if you hear there are conflicts, then you can go down the road of abuse. You can hear or you can see, because there is that the patient contradicts themselves. They say everything is fine and they start crying. So their mouth is saying one thing, but their body is acting a little bit different. So you should also look at the non-verbal part of their communication. Okay. Now, after you found out about the home, then you want to go into medical conditions so that your family history can be nice and rich, not just asking people, is your mother having diabetes and hypertension? No, please, okay? Now, sexual abuse. Yeah. If you are in the emergency room and a female patient comes in, Samantha Jones, 22 years old, has come in with concerns. You walk in, hello Samantha, my name is Dr. X. I'm one of the juniors here. And she's very quiet. Okay, Samantha, please, we said if you looked at my recent teachings, this business of trying to coax the patient to talk to you with confidentiality may not work. Or we are going to be very confidential. I'm not going to share anything with anybody but my team. There are some conditions that we have to call the police. There are some conditions that we have to involve other parties. So don't trap yourself in words that you can't commit to. Okay? And there are so many psychological and social diseases that you can be tested on that will see, are you just offering false reassurance just to get this person to talk to you? And sometimes even the points in the exam won't matter. If you talk to her and she says, I got sexually assaulted, a couple of minutes ago. I'm sorry, Samantha, first of all, can we call somebody for you? No, doctor, I'm fine. Okay. It is important after a sexual assault for you as a doctor to work fast. Of course, you're going to show your compassion, but would you want to alert someone? Yes, because they have to do the rape test, they have to do the kit, they have to do the speculum exam, they have to take samples, they have to notify the authorities. If this happened like an hour ago, of course, we are going to treat her, but time is also of the essence because this culprit needs to be found. Okay, so these are some of the things, and these are some of the things that are important for you to invest just a little bit of knowledge when you're studying for this exam. And for those of you who haven't booked, it's a blessing in disguise, yeah? For those of you maybe who are not in the UK, it may be a blessing in disguise for you to just go through these cases and just talk about them and brainstorm with each other. You have a man coming in and they are looking thin. All their pipes are showing, very emaciated. He says he lives with his daughter. Wouldn't you want to investigate a little bit more? And such cases need social services. So a patient who's telling you, I don't want social services, they are part of the team. As much as I am part of the team and my registrar and my consultant are part of the team, so is the social services. And they're not here to get anybody in trouble. They are here just to look into the matter. Because when you throw in words like they're going to investigate, it puts the patient off. Oh, they're going to investigate against my daughter. I don't want my daughter to get into trouble. I don't want my husband to get into trouble. You'll make people run. So your words have to be very, very, very careful, okay? Please, if I was you, I would look into some of these blueprints, yeah? Now, other things that I noticed, pathological gambling. A man is coming in and he's having troubles gambling, or his wife has brought him in. He's wasting all the resources of the family. It could have a psychological root. So where is this coming from? He may have a whole history to tell you of, I've been trying all my life to make it in life. But I just can't seem to make ends meet. Does he need somebody to talk to? Of course. And sometimes saying, I need to send you to a psychiatrist, sometimes it rubs patients in not a good way. So sometimes I usually say the words, let me see if one of our counselors can speak to you. telling a patient you need cognitive behavioral therapy. Wow, that's medical jargon. You'll be flagged for medical jargon. They don't understand what you're talking about. Okay, but if you fall into a case that you have no idea about, the structure that you have learned with the past history, the present history, and the future, and thinking about their future management can help you go a long way. When did you notice that you're having a problem gambling? And I would even now try and use it like an alcoholic history. Okay, like remember when we did alcoholic history, and it's not just about cage. Do you feel like cutting back? Are you angry when people talk to you about drinking? Do you feel guilty, and do you take an eye opener? Some of these psychological personality disorders, habit disorders, cannot just be solved or diagnosed with 4 questions. Okay, so I would take them to a prolonged history of when did this start? Okay, and where are you gambling? Are you gambling locally? Are you gambling online? Okay, just to find out how much money do you usually invest when you're gambling? Have you talked to anybody about this? Do you do it alone, or do you do it with company? Because one bad apple will spoil the rest. You have to find out. Okay, it's just like using drugs. So such cases should not alarm you if you find there's a case that I've never heard about. Goodness, I don't know how to do it. You can use the same templates in trying to navigate your way. How are they feeling now? Do they have any regrets? Have they made any decisions that have compromised their livelihood with the gambling, with the alcohol, with the cocaine? Okay, so you can really paste some good templates on some of these disorders. Okay, now pyromania. Let's not even get to pyromania and all these other things, but it's important for you just to go through them. Panic attack, obsessive compulsive disorder. A man is coming in and their hands are red raw. Do you want to at least bandage them? Do you want to take a look at these hands? Will this man need some counseling? Of course. But do you have to ask all the other questions? Yes, related to psychiatry. And I have a couple of, maybe I'll discuss these cases maybe on day 3 when I'm doing that OBGYN pregnancy and preeclampsia. Maybe I'll just throw these in so we can talk about them a little bit more. Okay. Sepsis, big time, my friends. You have to know sepsis. Sepsis, SIRS, okay? Sepsis, septic shock. You have to know the differences of all these things. I've put a nice, beautiful template on Facebook. Go and read through it, okay? But do you understand the seriousness of sepsis, okay? When you walk into a room and a patient is looking a bit obtunded, they're looking a little bit dizzy, what is going on? It could be a low blood sugar, it could be a low blood pressure, it could be a high temperature, it could be a low oxygen. That's why you need to do your vital signs so that they can guide you in the proper path. And we'll talk about the management triangle. Okay, getting to the patient, putting your vital signs, doing an intervention. You cannot forget your ABC, okay, your airway, your breathing, your circulation. So if you're walking into a patient and they're hypotensive and they are febrile and their oxygen is low, you want to fix that oxygen fast. You cannot start treating a temperature even though they are boiling and smoking from their ears. You cannot touch that temperature before you do blood cultures. Okay, now, do you understand the seriousness of sepsis? Do they understand and apply the principles of managing a patient with sepsis? Sometimes you don't even need to talk too much. You need to manage more than you speak, okay? Involves the infection control team at an appropriate early stage. Okay, so you've checked your vital signs, you've corrected the oxygen, you've put in your 2 large bore IV cannulas, you've started a fluid challenge of 500 mLs, okay? And then even at this time, you're noticing that the patient is getting hypotensive. Can I please get some assistance from a senior registrar? James, I'm going to continue to try and stabilize you. Don't be alarmed. And you may see me moving, rapidly around you. I'm just trying to get you stable. That's what patients want to know. They're sitting there, they're seeing all these people running in. That one is coming in, they're taking off their trousers, putting in a Foley catheter. Nobody's telling them anything. Now the FY2, that's your role. You're supposed to kind of guide them. And even when I teach emergency medicine, I tell the doctors, stand by the patient. You can't be sitting down and barking orders to the nurse. Nurse, put in the IV, put in the airway, do this. They're not your servants. A doctor takes care of airway and breathing. You want to be at the head of the bed. And now in this day and age of the C19, we have to up our game and learn how to stabilize an airway before the anesthetist comes in. Okay, you need to know how to bag and mask a patient. You need to know how to put an oropharyngeal tube and a nasopharyngeal tube and to measure them accordingly. Okay, so your nasal pharyngeal tube, and I'll talk about, this is just the introduction day, so don't be alarmed. I'm just throwing, you know how I do. I throw so much on the first day, and then now, as we move on, I'll try and hash them out. Okay, can teach this Plab forever. Yeah, you have to know these things, because what COVID taught us is that, goodness, can we even teach our nurses how to intubate patients? Will a patient die because everybody is waiting for the anesthetist? Come on. Doctors now have to learn how to intubate patients, even medical students, or at least stabilize an airway. Okay, so now at least the standard is being pushed up a little bit. Okay, takes appropriate microbiological specimens in a timely fashion, follows local guidelines and protocols for antibiotic prescribing. Okay, very important things. Now, focused history, physical examination, specific investigation, and a safe plan of care. This is what you're thinking of when you're going in to meet a patient, okay? Of course, if you're working in the clinic and you have 2 hours to talk to one patient, by all means, take your time. Find out whether they like to run outside for 15 minutes, whether they do some warm-up exercises before all these things. But in a timed examination, it shows your system of thinking and your organization if you can plan your time well. Remember, these examinations have been tested with doctors at your capacity. So they'll have an FY2 do a station, they'll have a medical student do a station, they'll have a registrar do a station, of course, for their specific examinations. And now they'll expect at this level, this doctor should be performing in this capacity. Okay, a patient who is having problems with eyesight, and that's why I keep bringing it back, because people have been failing my mock with a patient who's coming in and they can't see, yeah, and I'm holding my head and I'm saying, doctor, I'm having a hard time, please, I can't really see out of my right eye. Okay, when did it start? It started this morning. Has this ever happened before? No. What do you do for a living? Really? What do I do for a living? I work in an office. And that's the thing. The simulator will just entertain your questions until time is up. But you've already failed because you have not shown that you understand here. Okay? Appropriate early stages of alerting people who can prevent irreversible damage. Timely fashion. So sometimes you may think that you're being marked on time because you didn't finish a station, but you could be marked in terms of time and your management. Okay, so those are a few things. Now, let's talk about history. Yeah, because we are doing a review, and I'm not going to talk about this in the rest of the review. The rest of the review are going to go into very specific, challenging cases common in the NHS. Yeah. Now, what are they expecting from you? Focused family history. Constructs and interprets a family tree where relevant. Takes an occupational history where relevant. Obtains collateral history when available. Okay, and I'm being dramatic because if you are in a room and you walk into this scenario, okay, Samantha Jones has been admitted to the ward with atrial fibrillation. The doctor has decided to start her on anticoagulation therapy. Common case in cardiology ward. every other room, okay? You walk in and this is what you find. What do you do? Why do you think that all these people are in this room? Okay? They want to see how will you act with a patient and also their family. Don't you understand that they are also experiencing the sickness by terms of connection to the person lying in the bed? Of course, you're not going to go around and say, hello, my name is Dr. X. What's your name, James? Hello, what's your name, Sally? And you, baby, hi, baby, what's your name, Jimmy? And you, John? And you, Martha? Okay, do you have concerns, all of you? You have to show that your focus is the patient, but you acknowledge the people in the room. So if I walked into this scenario and I was supposed to talk about anticoagulation therapy to Samantha Jones, okay, Samantha Jones has really changed all through my courses. I'd go to Samantha first, but would I have a smile for these people in the room? Yes. Please, a smile does not cost anything, but gives everything. Okay? Please, just small smile. Look at them. Hello. Hello, Samantha. My name is Dr. X. I'm one of the juniors in this department. Okay, I can see your family is here. I have a couple of things to discuss with you. Is it okay for them to be here? Because let's say you have to talk to Samantha about her sexual history and her big brother is there. How uncomfortable is it going to be for Jimmy and for Samantha at the same time? These are just basic things that maybe people forget and think medicine holds priority over these things. You can be disqualified by just failing to do cheap things, okay? I can see your family is here. I'm really glad when I see, a patient's support, coming to visit them. It really makes my heart happy. Okay, maybe that's a little bit too much IPS. I'm happy when I see a patient accompanied by their friends and their family. Okay. I have a few questions, or I have a few things I would like us to go over. Do you want them to remain in the room? If she says no, then you just want to look to them, arms open, and say, thank you so much, please kindly wait in the waiting room. I will complete my assessment with Samantha, then I can come for you afterwards. You cannot continue an assessment or history or anything with the family in the room and the patient does not agree. Okay, but what if she says, yes, they can stay? What is your next step? You want to say, there are a couple of parts of the assessment that may seem, a bit off, or, a bit personal. We may discuss some very personal things. I will alert you before I start these questions. At this point, if you want your family to be excused, please let me know. Okay, so Samantha, I can see from my notes here that you have been admitted with atrial fibrillation. Did any doctor talk to you about it? No. Do you have any questions about atrial fibrillation? Never ask anybody, do you know what atrial fibrillation is? Do you know what the spark plug is in your car? If you ask me, maybe now I know, okay? But it's so hard when an expert asks somebody who is of the general public such a specific question in medicine. It does not, it's rude. Don't do that, please. Don't go and ask your patient, do you know what this is? Assume that they do not know. So, as I had taught before, you want to say, just as a recap, atrial fibrillation, you have chambers in your heart, top chambers and lower chambers. They usually should contract in an orderly fashion, one at a time. Sometimes, because of different conditions, you can have fibrillation, okay, or quivering instead of a contraction. And the problem with the quivering or the fibrillation is that the blood can pool, okay, in parts of the heart and can become clotted. And the clots can move to different parts of the body. Okay, and this is why, as per my medical record, I can see that the consultant has decided to start you on anticoagulation therapy. And I trap so many robots because I don't know how they switch anticoagulation therapy to warfarin. Did the doctor say warfarin? No, he said anticoagulation therapy. First of all, start from the beginning. Anticoagulation therapy is to prevent coagulation or the accumulation of that blood into clots. Because what is dangerous, some of the blood vessels are very thin, especially those of the lungs, those of the extremities, and some parts of the brain. They can get dislodged, or they can get lodged or fixed in a vessel. And once you have a block in a vessel, the tissue that was being supplied now lacks oxygen and nutrients and starts to die. Okay, I don't mean to alarm you, but I just want to also alert you to some of these symptoms when atrial fibrillation is not managed. Have I started talking about her other medical conditions and allergies and family history, whether she takes herbal teas or over-the-counter medication? No, because in this scenario, it is important for her to understand her disease and then understand the medication and the compliance with it. When we do surveys for patients, honestly, the biggest point of non-compliance is because the doctor didn't take time to make them understand what this disease is. Okay, so take at least a minute to talk about atrial fibrillation. Talk to her about symptoms of a stroke. Okay, some of them can be very subtle. Just a mild headache. You're noticing that, your face is feeling a little bit funny, or your sensations are going, or you're drooling, or it's really not that easy to pronounce some words. A bit of pain in the leg, trouble breathing, chest pain. Okay, which can present differently. Epigastric can present as pain in the arm or in the jaw. That's what she needs to know. Do you need to know where she works? Okay, and then now when you're talking about the anticoagulation therapy, you can't just, I don't know, honestly, when I do a mock with this station on atrial fibrillation and a cardiologist ordering anticoagulation therapy, 3 out of 4 doctors, I don't know where, in between reading the question and sitting in front of me to do the mock, it has become, oh, we are going to start you on warfarin. The consultant did not specify. So what are you supposed to do? Talk about broad anticoagulation therapy. There are usually, well, there's some medications that have been in the, in service for a very long time, and they have proved their worth. One of them is called warfarin, okay? And it is actually ordered according to your PT-INR levels, where we are checking through regular blood work how thick or how thin your blood is, okay? If your blood is too thick, then the dose goes up. If your blood is too thin, then we reduce the dose. So we are trying to get to a normal balance with this medicine. That is why it is important for you to take it regularly as prescribed. With all anticoagulation therapy, you will get an anticoagulation card. Okay, it states the condition that you have and the management that is being given. And on top of that, I would like to make a small card for you with FAST, okay? And you take a pen and paper and you write it down: face, arms, okay? Call 999, okay? If they're having the face symptoms, problems with speech also, okay? That is how you catch the heart of a patient. That's how you hook a patient, by showing them that you're interested in it. And then now what if they say, I don't want to have regular blood tests? Okay, do you work for the warfarin company? Because some of you have asked you in the mocks, do you honestly work for Glaxo and SmithKline or whoever makes warfarin in this country? Because you push the patient, no, warfarin is the best, it has gone through clinical trials, some people think that it's really not that good, or it has been associated with as a rodenticide and all these things. And I'm like, wow, you have shares with warfarin. How can you come in and push for one drug You want to say, no problem, if you're not comfortable with doing blood tests every day, there are other types of medications that can be used. And maybe I can sit down with you and talk to you about the pathways that a blood clot can be formed. And different medications can block these pathways. Of course, you're not going to start talking about factor 10A and factor 2 and prothrombin and all these beautiful things. She's not interested. Not everybody is a geek like us, okay? But is it good to just mention we can attack the blood clots from a different pathway with other medications? For example, there's one called apixaban, okay? There's rivaroxaban. You know why? Because XA is the pathway that it blocks. Giving you a little bit of a pal. That's why they're all Xaban, okay? And the beauty of these medications, yes, they are new in the market, but they are proving their worth. You do not need a blood test every day, okay? There are antidotes that are available, okay, for them at Nexa Alpha. So please, Samantha, if you don't want this old man warfarin, we can give you one of the new Maserati drugs. Yeah? Okay, good. Now, where would you go? Does she have to decide? No, the consultant will decide what medication you're going to take. All right, I can just go and check with him which one he has decided. Because again, atrial fibrillation can, and I want you to go and read about atrial fibrillation, because it's not all drugs that can manage atrial fibrillation. There are different types of atrial fibrillation. So please go and look into that also. That is homework for you, right? So that's the thing. If you're sitting down with the patient, another part of history taking, if this woman, or you read on the question, Samantha Jones, 14 years old, don't you want to find out how she got here? Where her parents or her guardians are? You need to know with sexual history or with anything to do with sexual health, these minors under the age of 18 can make their own decision. So you're nobody's papa and mama. They are trying to force her to talk to her parents, talk to your parents. I cannot give you oral contraceptive pills because you do not understand how they are going to be used. You are the one who's supposed to provide insight for the patient in order for them to show or demonstrate that they have understood that oral contraceptive pills are not effective. Okay, so those are the little dynamics that can be thrown at you. Okay, what if you walk into a room, and this is the thing, you walk into a room, Samantha Jones is at the bed, okay? You have a whole group of medical students. Do you just bring them all into the room and tell her, Samantha, I'm going to teach these students how to do a digital rectal exam? If I was Samantha Jones, I would just tell you, walk back out and never come back here again. How do you bring the whole world here to see? Did I sign up for that? You know, I've been having bowel problems. I noticed a little bit of blood in my stool, and the first day I've been here. Here is Dr. Lian coming with a whole group of students, medical students. That one has not tucked in their shirt. The other one looks like he's just eaten some burgers and he has food on his clothes. I tell my students, please, you are an attachment of my body. You are like a third arm to me. You cannot be coming here. You have just eaten spinach. I know. Why? You have spinach in your teeth. Didn't you just rinse your mouth before you came here? The medical students are an attachment of the doctor. Okay? So even when you're talking to them and you're talking to a patient and you're noticing that the medical student is not paying attention, please excuse yourself. Okay, in real life, yeah? But if you're in an examination and the student is not paying attention, first of all, you want to find out, are you having a stroke? What's going on? Why do you look dizzy? Why are you not focusing on what I'm teaching? James, I've been talking to you about how to manage a patient with atrial fibrillation, but you seem a bit distracted. Is everything going on okay? Is everything okay? And of course, do you want to blast the student in front of the patient? No. If I'm teaching Samantha Jones about atrial fibrillation and James is busy on his phone, oh, you better go find another junior doctor to follow because you'll never follow me again. you'll be blacklisted. I'll be seeing you from the door and say, go back. You're on probation. Because it's rude. The medical student is an extension of you, an extension of the hospital. They need to understand that. So if you see James busy twiddling on his iPhone 4, you want to tell him first, can you upgrade? I'm in a very happy mood today, guys. Sorry. I'm throwing out too many. I'm just happy to see you. You know, I haven't seen you in how many weeks? 2 weeks? Anyways. James, I can see you're on the phone. Are you researching what I'm talking about? Do you have any questions? Are you researching? Do you have any questions right now? You know, excuse me, Samantha, just give me a few minutes. Let me just make sure that James is on board. Inside, I'm fighting, but outside, let's just give him, you know, the benefit of doubt. Kindly, you know, you can refer to your phone after the session. Please move closer. You know, I'm really talking about something so important, James. One day you will be in my position and you will be expected to take care of the patient safely, okay? And I'm sorry if I'm maybe moving too fast. We can always go over what I'm talking about later. Can you please move a little bit closer? And he'll move closer and you can continue with the session. But if he refuses, are you going to start fighting with the student at the expense of the patient? You may want to tell the student, okay, I see that maybe, you know, maybe you did not quite understand what I'm trying to explain to you. You know, you are an extension of the doctor, you're an extension of the hospital. It's a bit rude that you're on the phone in front of the patient and we are discussing important matters. If you want me to excuse you, I can kindly excuse you. And sometimes James doesn't care, he's still on his phone. Then you want to say, okay, Samantha, let me just finish with you, then I can talk to James later on. Seems to be having a bit of a challenge. Finish with the patient, because who is important here? It's the patient. Finish with the patient, ample time, and then get back to James. You know, James, I was a bit disappointed with your behavior when you were with the patient. You know, patients and doctors have not always had a close relationship. There has always been an issue with trust between a patient and a doctor, and the doctors who have gone before us have really worked hard to build this trust. So if we're in a room and we're talking to a patient who's suffering and you're on the phone, it's first of all disrespectful. And now, because you are an extension of the physician, that patient now will think all physicians do not care. All they're interested in is their phone. I'm very sorry that it has come to this, you know, because I did alert you to put your phone away and you did not listen. I may have to escalate this to your educational supervisor at this point. And I hope that in the future, you will not present yourself like this, okay? Dan, I don't need to hear what you have to say. Get out of here. Wasting my time. Next time, I'll not even invite you for this teaching. Because some of these students, they don't understand, but some of them honestly are just ignorant. So they need a little bit of a teaching. And if you're in a station where a student is not paying attention, why did they tell them to act like this? They want to see what you would do in real life. Okay, so remember the settings, guys. Remember how to act in a setting. You're in a setting, you're asking, it happens all the time. You're asking Samantha Jones the questions, and here, Billy. Samantha, what did you have for breakfast? She did not even eat the sandwich. Thank you, Billy. Okay, did you have problems swallowing? Are you having any pain? No, my sister never eats. Billy, thank you so much for your input. It may be best to let Samantha answer the questions, and then afterwards, you know, you can contribute your suggestions. Yeah, a nice way of saying, shut up. Okay, but you never just want to say, hey, shh, everybody keep. No, they want to see how you can manage. And sometimes you may have to say in a room where they're all talking, you may want to say, excuse me, please, kindly excuse me. I always have my hands in the ninja prayer move. Excuse me, please, let's just have one meeting, okay? It is important for Samantha to voice her concerns. The rest of us will be quiet as she speaks, and then afterwards, one at a time, you can tell me all your concerns and whether you think that atrial fibrillation has been caused by her riding her bicycle. because everybody's input is important, okay? Manage. Can you get control? And some of us are a little bit timid, but for exams, hold it together for 10 minutes, for 15 minutes, for 8 minutes. Manage it, okay? Now, here, asks for chaperone when appropriate. Do I need a chaperone for an eye exam? Do I need a chaperone for a mouth exam? And I was talking to somebody about this in the clinical lab, and they're like, yeah, because I don't want the patient to think that I'm going to kiss them. I said, how close are you? You can't see the patient's mouth from this distance. How close do you want to get? That's why you need to use a flashlight. That's why a doctor without a flashlight cannot see. Okay, you need to have one. You have a pen, get a flashlight. I never get too close. If you're doing an eye exam, okay, then you get into trouble if you do not know it's right. So if you're right-handed and you're looking at the right eye, well, let's even give it in perspective of the patient. If you're looking at the right eye of the patient, okay, you want the fundoscope to be on your right eye. Because if you make it on the left eye, well, that is what is going to happen. You will go like this and your nose will touch the patient's nose. If you are right eye, patient's right eye, you will always be in this level. And I always stand to the side. So my fundoscope is always held like this. There's never going to be any sharing of space. Okay. Now, demonstrates another chaperone. Knee exam, foot exam, honestly. Chest examination in a woman, of course, because of the breast area. Anything pelvic, of course. Thyroid, really? Joint, hand. So it seems odd when you are doing a hand examination and you say, I will get you a chaperone. Okay. Now, routinely scrutinizes existing patient records and other sources or evidence of information. It is okay to take the paper and to look at it and say, let me just look through your medical record to make sure I'm not missing anything. But put the medical record down after you've gathered your information. Okay. Explains and gains appropriate consent for the examination procedure. Here, performs a mental state assessment. That you have to know how to perform a mental state assessment. And to take it a little bit deeper, learn how to do a mini mental state exam. Okay, so for example, just branching off a mental state assessment, does everybody get a mental state assessment? Does everybody get a GCS, Glasgow Coma Scale? No, only in appropriate scenarios. So I have a patient who's coming in, he's elderly, he's confused, okay. All I have to do is the nurse says, go and talk to James Smith, 68 years old. He's coming with confusion. What am I thinking first? Mini mental state exam? No. You want to make sure alarm symptoms have been excluded. Because as you're doing your mini mental state exam asking about apple, table, penny, James is going to die of hypoglycemia. He's going to die of septic shock. He's going to die of hypotension. So you want to check first your alarm symptoms. Vitals. Okay. Now, demonstrates awareness of safeguarding children. Please, any child who you have a suspicion of abuse, okay, you and vulnerable adults, I told you, the disabled, the dependent, the elderly, okay, who is a dependent? And a dependent person can be a 45-year-old who is living with her parents, you know, maybe because she has cerebral palsy, and they are taking care of her. So she depends on them for food, shelter, and clothing. Where will you find this information out? Is when you do family history. Okay. Let's move on. I've taken some good time on this history and examination. And now, here it is, the Foundation Program Curriculum 2012. Of course, they need to update that. But this is how it looks like. Okay. So if you have a chance, go and look at it. And I always say in my WhatsApp groups, I have some WhatsApp groups that are going on from, I think, January. People who are really taking their sweet time with this exam. There's a doctor who gathers NHS information, cuts some clips, puts it for the other doctors to read. There's another doctor who focuses on nice CKS guidelines, okay? Another one who goes to the foundation program textbook, okay? This one here, right? Gathers some information and just sends a message. Hey guys, there's on page 346, there's a section on seizures, okay? So there are worrying features, a headache, blah, 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 blah. And they have slowly begin to build up knowledge to be a safe doctor in this country. There are how many groups now? 3 of them on WhatsApp. You have now even your private Saturday, Friday groups and your small groups of 8 people. Please, please, please work hard, okay? Now, junior doctor skills. How are we doing on our time today? Okay, good, we're doing fine. Maybe tomorrow I can add a little, tomorrow I'll add an hour and we can do our mocks for an hour after class. This is important for you to know because I didn't mention that much of it when we were going through the extended course, okay? This is what a junior doctor in the NHS is required to know how to do. Of course, there are other procedures here that need for you to be under the guardianship or the mentorship of a senior doctor, okay? But look, if somebody comes to me and says, Dr. Leon, what procedures are there in the Plab 2 examination? I say, go to the Plab blueprint. It's right there. Venipuncture, how to get a blood sample, how to put in an IV cannula, okay? How to prepare IV medications, injections, and fluids, of course. Arterial puncture in an adult, how to get an ABG, and not just getting an ABG, how to interpret it, okay? So how do you interpret a metabolic acidosis? And not only interpretation, what is the solution for it? So you're taking it all the way to close the case, yeah? Blood cultures, how do we get peripheral blood cultures? It's easy, mannequins are cheap. You can just buy a mannequin and sort it out with a blood culture and make a station in the Plab. Can you get blood cultures on this patient? People will be so stumped. Oh, it's a new case, it's a twisted case. They already gave you the cases in their Plab blueprint, okay? IV infusion, including the prescription of fluids. One of the cases I want us to delve into is fluids. Resuscitation fluids. What fluids are important for when? Or do we just give normal saline? Let's just give normal saline to everybody. What if you have a group of students who come to you and say, we want to learn about fluids. What fluids do you want to learn about? There are so many fluids. There are fluids that have lactated ringers. There's your normal saline. Can we know, about these fluids? You have to know these things. You need to know how to give maintenance fluids, how to give resuscitation fluids, how to calculate fluids in an adult population and also in a child or pediatric population where we are calculating it using their weight. Please, okay? Now here, infusion of blood and blood products, injection of local anesthetic into skin. Oh yeah, I'm just going to go and give I'm just going to go and give an injection to a patient, and there you are pushing lidocaine into a blood vessel, forgetting to aspirate. Some people forget even to use. It's so surprising to me when I go to the lab and I have, there's a station for giving an IM injection, and there's a station for practicing suturing. Where? Because are we supposed to know how to suture? I think we are. Here. Where is it? Skin suturing in emergency medicine or surgery. You have to learn these things. So I have a doctor there. I say, okay, can you go ahead? Samantha Jones has come in with a laceration to her arm. Okay, I'm giving you 8 minutes to do a suture. Okay, yes, I'll go ahead. Goes right in, no gloves, no nothing, no sterile area. They just grab the thing. And this is a surgeon. They are so used to working in just this type of environment. And I said, did you come from Kenya where you don't have gloves? I'm from Kenya, so I'm allowed to make fun of my country, yeah? Even putting lidocaine. Are you going to suture without giving anesthesia? bad doctor. Okay, I'm going to give anesthesia. What are you going to give? I'm going to give the lidocaine. The nurse has drawn up the lidocaine. Give it. You want to check the vial. You want to check the vial to see, did Nurse Betty just give you water? Or are you comparing the vial and to compare and see that this is lidocaine that this Nurse Betty has drawn up for me? You need to do all these steps. And then when you're injecting the anesthesia, you want to draw back, aspirate to see that you're not in a blood vessel, okay? Some people, when they're giving anesthesia, they use almost 5 needles. One here, toss it. Another one here, toss. I said, wow. No, you push that needle in, give a little bit of anesthesia, pull out, put it in another area, give, put it in another area, give, put it in another area, give. Why are you giving the anesthesia into the open wound? So I can see all the medicine just pouring outside and flowing on the skin. Such things, please, 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 even in your workplace, look for opportunities to try and develop some of these skills, especially IV cannulation. Some of you, when you graduated med school, you're like, that's the job for the junior doctor. I'm done. I'll never do it again. Okay? Can you perform and interpret an ECG? The biggest thing about such a station is actually not even interpreting it, the ECG. Well, okay, maybe what, 80%, but do you know where to put the leads? Do you know where to put the leads if the patient has bilateral, above the knee amputations, above the elbow amps? Do you know? Please, okay? Performing and interpreting a peak flow. I remember I taught you that one. You can easily go through it again. Catheterizations in females and males. Airway care, including simple adjuncts. Wonderful. There's your oropharyngeal tube and your nasopharyngeal tube. Okay, now for each procedure, foundation doctors should know the indications and contraindications. Before you start doing a speculum examination of the female patient, please find out when was your last menstrual period, because if she's on it, good luck. Okay, you need to know that Foley catheters cannot be inserted in somebody who has had a pelvic injury and they are bleeding from the meatus. Goodness, please, okay, I'm like almost begging. Preparing the required equipment and including the sterile field. The sterile field belongs to the doctor who opens it. So you can't be asking, examiner sir, where is my sterile field? It's on the floor. Ah, goodness. Okay, please. Okay, now and here are other procedures that you need to do, to maybe have an idea about, because you cannot perform them alone as an FY2. Of course, you'll need a specialist, but just to have them at the back of your mind. I have a friend who was actually told on his first day as a junior, not even FY2, FY1, a patient comes in with ascites, and he was told, can you go and put in a drain? And he's like, what? A drain for ascites? I don't even know how to do that. So of course, you observe one, you look at one, okay, you perform one, and then you teach one. So that's usually the system. If you do not know how to do it, then you need to find somebody who will teach you how to do it. And then after that, you perform it independently, and then you can teach somebody else to do it to close that cycle. But it's important though, okay? Suturing is important. Fracture manipulation, you're going to get shot by orthopedics if you just go in there and start twisting people's arms. Insertion of an NG tube is standard FY2. You have to know how to do it, and I'm teaching people also how to do it in the lab, okay? Now, how are we doing? It's 1:12. Can we take a 5-minute break? Let's take a 5-minute break, and then we'll get into maybe 1 or 2 cases for today. Then we'll call it. We have 5 days, so please, I hope you're not going to be disappearing on me after the break. 5 minutes, 10 minutes? Let's take 10 minutes, and then we'll be back, okay? See you soon. And we are back from our break. Let's do that. Let's do this. And let's do that. I'm glad that you're all happy to be here. Practicing your IPS on me. Okay, good. So let's get into a bit of pediatrics. Where was I? Good. So now you know what is expected of you in terms of skills. Okay. These stations, expect them, please. And they can come in as combined stations. So maybe you have to talk to a patient who is going in for pre-surgical, she's been prepared for surgery for, let's say what, hernia repair, that's the most common. And you have to put in a cannula. So you go in, hello, Samantha Jones, my name is Dr. X. I'm one of the juniors here today. I can see you're going in for a surgical procedure. Yes, doctor, I'm going in for a hernia. How is your pain level right now? My pain is okay. I can ask you a few more questions, but it's important for me to secure an IV cannula before we can proceed. Why? IV cannula will take you at least 4-5 minutes if you don't miss. Okay, if you miss, you need to do it again, so add more time. So what have I done? I have indeed asked, I've not just walked into the station and said, I'm here to do the IV cannula, let's go. No. Hello, Samantha, how are you doing? Just to confirm your name and your age, you're here for a hernia procedure. Yes, how is your pain level right now? It's quite painful, around 6 out of 10. Okay, some medications can be administered by IV. Why? Because you don't want to start saying, okay, do you have any allergies? Can I start giving you paracetamol IV? I'm going to give you morphine 5 milligrams to relieve your pain. That's not the theme of the station. The theme is to put the IV cannula. So nice and focused history, and then get to it. Let me prepare some of the things that I will need. Remember when I taught you about examinations, P, E, C, C, D. What is this procedure? You have to tell her the procedure. I will be putting in this IV cannula into your arm. I've chosen not a big one, moderate size for IV fluids, okay? And sometimes, even another thing, IV cannula sometimes I put in when the patient's asleep. But anyways, let me just leave all that out. So, procedure. What are you going to do? You have to tell her, I'm going to put in an IV cannula into one of your veins, sharp scratch, okay? We'll flash it, make sure it's working okay, all right? I just need to see your arm where I'm going to be inserting the cannula. Do you have any medical conditions? Have you had any rashes on the skin at all? No, doctor. Have you had any injuries to the area? Are you on any anticoagulants? So those are some of the questions I usually like to ask. That way I can prepare myself. Am I going to have a fountain of blood pouring out from this woman because she's on warfarin? Okay, then after a few questions, then you can ask which arm should we use. But the essence of the case, why I'm telling you, it could be coming in hidden as the patient is going in for surgery, or she's requesting, or maybe the consultant wants to start antibiotics or wants to start IV heparin. Get a little bit of information concerning that disease, but get to it. Because an IV cannula on a good day will cost you 4 minutes. Okay. Now let me move on a little bit here. Now, past, present, future we talked about. Old cat we talked about onset, location, duration, characteristics, AAA, associated symptoms, alleviating symptoms, aggravating symptoms. Where is this pain radiating to? Okay, and have they sought any treatment? Okay, there's different approaches to different systems. You can use the past, present, future, like how was your past health? Have you seen a GP for any reason? How do you maintain good health? Do you diet, exercise? How is your sleep? Good. Any stress in your life? Any recent screenings that you have gone to for with your GP? Colonoscopy, breast examination, mammography, all these things can be in the past health. What happened between then and now? Did you travel? Did you have any sick contacts? Okay, is this something that has been going on in the family? So there's really no fixed template that you can use. But if you want to cover most things, this is actually what I use in my history taking. Then I add other things like Socrates. I add other things like old cat here and there. Okay, present. How are they doing now? If they're unstable, remember vital signs. How are they doing? How are they coping? Okay, do they have any other complaints? Do they have any other concerns? And you always want to think, future, how do I prevent this patient from coming back again with the same disease? Because that's a good doctor. A doctor doesn't open a tab like at a bar, to keep the drinks flowing. No, a good doctor wants to close a case. If I don't see you again, Samantha, in this environment, I have done a good job. But if I keep seeing you back here all the time, it's because I'm missing something, or we are not, maybe your condition is too accelerated for me. I need to refer you to somewhere else, but I want closure. Okay, so there are different approaches to different areas, and I'll try and cover most of them during this review. Okay, now this is what I was talking about, your old cat. It looks a little bit different. This is the Maserati old cat. I know those who've taken my course are just seeing white and black on screens, but I try to make it a bit pretty. Yeah. Onset, location, duration, characteristics, associated factors, alleviating. And you're not saying these things. You're saying what makes it better. Rest, movement. What makes it worse? Rest, movement. Okay. Is the pain moving from your shoulder to your arm? Is it moving from your chest to your jaw? Okay. Treatment. Is this the first time? Okay. Then you can ask any other concerns. Find a way to put your concerns in the middle of your history taking, and find a way to ask about coping, especially even to a family member who is asking you for an update about their patient. Okay, so if a husband is coming in, I want an update on my wife's problem. Maybe she has bowel cancer. How is he coping? Because he shares the disease with his loved one. That is why coping is important. All these people who are coming into the room are sharing that burden in their own different way. Sometimes we may need to offer psychological support. Sometimes we may want to spend a little bit more time with them and just make sure they're okay. Like being posted to pediatrics, and you have a twin in the bed, and who fell off his bicycle and he has 2 broken legs. How that happened, I really don't understand. But I want to find out, Billy is in the bed, he's sick, and his twin brother is right there. How is Tommy doing? How are you feeling, Tommy? Do you want to talk about anything? Are you having any scary thoughts? Any worries about your brother? I can see how attached you are to him. You've been here every single day after school. You want to find out how the other party is coping. Now, good. When we get into pediatric history, and I'm happy that we'll get into we'll get into a pediatric case today, and then we'll follow through tomorrow and bind and mix it up with an adult case, yeah? What is the chief complaint of this patient? Or most of the time, the mother is complaining about the child, or the father or the guardian is complaining about the child, okay? What is the child's medical history? Then the maternal history, then the family history, developmental, and school. So if Tommy is coming in and he is constipated, he's having a hard time sleeping at night, his grades are falling in school, he has become very isolated, okay? My child Tommy is 3 years old. All of a sudden, or 13 months, let me choose 13 months so I can associate it with autism. Tommy is 13 months old. Samantha Jones is concerned that he's all of a sudden not, interacting with the rest of the family, okay? You want to start from the center. You found out who Tommy is, you found out his age, okay? And you're referring to him as Tommy. You're not referring to him as baby Tommy, as your kid. You're not referring to him as little one, okay? Is he your nephew? No. So stop giving him pet names. Okay? He's not your little one, okay? And another big thing, He versus she, gender. Please, that is one. And I know we did not come out of the hospital speaking in English. Some of us have learned English as our fifth language. But the basics of he and she are basic level English. You will not be forgiven for referring to a girl as a boy and a boy as a girl. So you have to practice he for boys and she for girls. I am stressing on this because I have so many people who give me excuses. That's my culture, you know. So in my culture, everybody's she. I'm like, which culture is that? Huh? I get confused with he and she. I'm like, you're coming to England. English is their language. Don't confuse on genders. Some people get very irritated and have said, I told you my child's name is Sally. Why do you keep calling him he? So your interpersonal skills are decreasing because of this. And there's no excuse. Come on, we can work. If we can understand medicine, English is just a breeze, okay? So try and develop it. Please don't make that mistake of he and she. So Tommy, 13 months, is now playing alone by himself. Your mind is thinking, don't we know that there is solitary play in a child of 12 months to 30? They like to play by themselves. They are selfish little critters. So it's not always to jump on autism. When did it start? I noticed it about a month ago. Was there anything specifically going on with the child? Okay. Well, you know, my child he's just staying there. I'm so worried. Okay, you know, before we even go on, what is your concern? I'm concerned he may have developed this autistic spectrum or Asperger's. Okay, how are you familiar with these terms? I looked online. Okay, Samantha, you know, online is actually a good place for a resource for other fields, but not medicine, because there is just so much information that is ambiguous. Most of these people who are using these websites are not physicians. So most of the time we refer our patients to NHS website if they are looking for information, or to come in and sit with a doctor. If a patient is telling you they are getting information from the internet, you have to correct them. The internet is good for many purposes, but not for medications and for medical knowledge. So I'm glad that you're here now. Asperger's, autism, and all these other are on all these developmental or psychological or some of these things that are termed as disorders and diseases are actually not diseases. It is just the child having a different perspective on how they look at the world and how they interact with it. You better not do a mock with me and tell me they are autistic and it's a disease that cannot be cured. No, they just appreciate the world differently. Okay, they express themselves differently. Other children will express themselves with speaking, others will express themselves with song and music. The children in this group express themselves maybe in different attachments. Please, okay, it's not a handicap. So don't refer to it as that. And why do I do this? Is because I've read up on it. Okay, go to all these autistic websites and read up on how they describe some of how developmental psychologists are describing these conditions. Okay, so now what is going on with him? Tell me what he does in his 24-hour period. He wakes up, I give him a shower, he eats, and then he goes to the corner and he plays with his red truck. All right, for how long? Or he plays with it all day. He does not want to do anything but just play with the truck. Okay, you have now exposed everything about that complaint. So now you can move to the next tier, medical history. Don't start saying, okay, he's playing around with the truck. Who is in the home? Then your back, okay, does he get irritated? Does he have any problems with moving his joints? Does he flap his arms? All those questions about the child should be asked in one setting. Then now you can ask about the school. Then you can ask about the environment. Then you can ask about the family. Why people get problems with consultation is because they're asking about the child, then they ask about maternal history, then they come back again to the child, then they ask about the school, then they come back and ask about the sister, and then now they ask about living conditions. You're zigzagging. Okay, it's showing that you're just throwing out questions. You want to start in this fashion, and this is what I teach my students for pediatrics. A child is coming in and they're not sleeping at night. Okay, when did this start? Old cat onset. When did it start? 2 days ago. Has anything changed in their health? Have they had any injuries? Are they waking up screaming? Do they wake up frequently to go to the bathroom? Because I'm now thinking, is it a terror in the night? Is it early onset juvenile diabetes? Are they just scared? Okay, and then now after you find out about the child, including their medical history, then now you can go to the home. Who is in the home? The father, the mother. Have they visited anybody recently? Have you had any visitors to the home? Are they scared of anybody in particular, or are they changing their demeanor or their attitude when anyone specific comes along? Okay. If the child is screaming in the night, of course you want to find out about that scream. What are they saying? Are they saying words? Are they just shouting, ah? Or are they saying a name? Billy, Billy, Billy. Who's Billy? Okay, maybe Billy is the big black bear in the cartoon that is scaring him. Okay, is this a seizure? You want to find out these things. Has a child experienced any traumatic event? A loss? Have they moved? Now after you've talked about the home and the environment, is there any conflict going on? You've even find out if they've gone to spend the night in somebody else's home. Then after that you can go to the school. How are they doing in school? Have their teachers complained about their lack of concentration? If they are screaming in the night and shouting and not sleeping, is it affecting them? Okay, how are their grades? Now when you're managing pediatrics, you can manage from the outside going in to squash the problem. So let's talk to the teachers in school. Let's set up a meeting. Let's investigate who his friends are. Is there any bullying? Then in the home, talk to his brothers, his sisters. Okay, and another thing you could have asked when you are moving out is to find out, has anybody else experienced this type of behavior in the past? Any of your other children? Honestly, you don't even need to know what recalls people are having in this exam, because you've already organized your pattern of thinking. And solidifying this type of question asking takes practice. So that's why I really encourage people to practice. So you've managed the school, now you're in the home, find out if there's any conflict, and then now the child. Is he at an age where you can talk to him? He's what, 6 years old? Take him out for, for a little treat. Make sure he's nice and relaxed and just have him talk. Does he have a journal? You can have a mommy Tommy journal where you write your thoughts and Tommy writes his thoughts. That way you can get to think, to see what he's thinking. Sit down with him every day and go through his journal. What is making Tommy sad? What is making Tommy happy? Okay, let's have a sleep diary. Wake him up in the middle of the night. Interrupt this cycle that he's having of screaming or yelling or crying or all these other things. So the case really doesn't matter. It's how you organize your information of collecting. You have gone out into the fields to collect the strawberries, and now you are bringing them back home. And in the end, with every child, it's important to tell, especially children who are maybe school age, the school age population, safety checks need to be done in the home. Can you take some time and just go through his things? Around school age children are so secretive. You know yourself when you are a school age child, how many things you bringing in dead frogs in a bag and cockroach legs, okay? I didn't do that, please. I've always been very professional and sophisticated. Anyways, yeah, check his bag. Does he have a phone? Check the parental settings and the passwords. Check a safety check. Don't tell the mother to be nosy. It's nosy parent safety check. Do a concerning check. Check under the bed. Check and see whether he's, withholding any secrets from you. And every child we at least need to see at some point. So even when you're doing pediatric medicine, you have to think like a pediatrician. Even though you have 10 years of cardiothoracic and neurosurgery experience, as soon as you see your question says you are in the emergency room, switch to an emergency room doctor, switch to a pediatrician, switch to OBGYN, because they have different focuses, okay? What do you expect to see in a pediatric ED ward or clinic? Pediatricians love milestones and vaccines. So even in this exam, when people say, what are some of the things I need to study for pediatrics? I said, what would be important for a pediatrician? Pediatricians know their milestones and they know vaccines, so at least practice those. Know what vaccines are given when, okay? Look into, the big thing with vaccines is the whole movement of, no vaccination for our children, because it's causing MMR, or it's causing Asperger's, and I'm sorry, not MMR, it's causing autism, Asperger's, okay? Look into those things, because they are specific social issues that occur in each and every system. Okay, lean on the side of caution when you're doing pediatrics. You want to see the child. A mother can come in and say, my child has chicken pox. How do you know? I know chicken pox. Do you have a picture? The mother shows you a picture of meningitis and you're like, golly, Samantha, this is not chicken pox. These spots are black and they are all over the body. They are flat on the skin. Look at your child. He looks like, is that drool that I can see on the picture? His eyes are rolled backwards. Then you're thinking, instead, bring the child over. Even with an adult who's coming in with something very contagious like meningitis, and who is in the home, how are they? I have 2 twin boys. How are they doing? I left them sleeping. They seemed a bit lethargic. Because you've told me you have a headache, you're sensitive to the light. Okay, your neck is a little bit stiff, you have a fever and you have a rash, and now you have 2 boys at home who seem a bit lethargic. Can I just have a check on them? We can even have an ambulance go pick them up and bring them to the hospital. Never dismiss a mother's concerns. She may think it is not serious, but because she took up the phone to call you and say, my child had a seizure, in a court of law, you'll not stand, because the mother did her rightful duty to call and say, my child had a seizure, he's okay now, he's playing, he seems like everything is okay. Did he have a fever before? Okay, everything was fine. How often is he having these seizures? Doctor, he's had this seizure, about twice in the last 2 weeks, okay? Or maybe this is just the first time that the child has had a seizure. Just to make sure that the child is okay. I know he's playing around and everything is okay. Can we just have you make an appointment with his pediatrician to see him within the next couple of days, just to make sure everything is okay? The child is playing around, but at least let's mention it to the pediatrician in the next 1 week when you go and see him. Okay, you never just want to say that was just a febrile seizure. If it happens again, give them paracetamol. If it goes beyond 5 minutes, you need to call the ambulance. Those things are good, but somebody needs to see the child. Okay, now, if you show concern for the child, you'll be friends with the mother. Okay, is this 100% true? Of course not. Nothing is 100% in medicine. So you can be the sweetest doctor and even talk to the mother, but she doesn't care what you have to say, especially if you've made an error, especially if you've made a big error. Samantha Jones has her child who is has come in for a checkup, the nurse has mistakenly given the child vaccinations. Oh my gosh, Nurse Betty, you confused the rooms and you went and you gave that child vaccinations and they've already received the MMR vaccine. Now you've given them another dose. An error on a child, the mother is going to be livid. So what do you want to do? Make excuses? No. You want to let the mother vent. You guys are idiots. I should have gone to the private care hospital. You know, I should not have come to the NHS. I've been warned against the NHS. Even when we were clapping for you, I was not clapping. You know, what do you want to do? You just want to take it. Take those slaps. Let her give you a good thrashing. Why? Her child almost died in the hands that are supposed to save her. Big paradox. So after you hear her complaints, and if she's just blah, 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 you've given my child the wrong medicine, you gave my child the wrong jabs. I can't believe you guys, you took out you took out tonsils on my child and they were not supposed to be taken out. All these errors that we are doing to these poor mothers. What do? You sit down, you listen, wait for her to vent, and then you never interrupt somebody who is angry. You never tell them, you look angry, you look frustrated. I can see that you are very disheartened. They will punch you. No, you want to let them vent, and then if you are lost in all the confusion and you're so frazzled, bring it back to the center and say, you know, I'm very sorry. I am very sorry with the events that have happened. In order for me not to miss any of the points that you have stated, can we do a recap, please? You said you came into the hospital and your child was supposed to get the MMR vaccination and they got the chickenpox one or whatever. Or your child came in for a checkup and was given their double dose of vaccinations, okay? Usually, we do not, okay? Usually, we do not, how can I talk to a mother like this? Let me think quickly. She's vented, you've recapped, she came in, the child had an ear infection, we've given him the wrong antibiotic. All right, I'm very sorry. We take errors, we take our mistakes very seriously. We want to find out everything that happened, okay, in a step-by-step fashion, and look or investigate and make sure that it does not happen again, okay? Before I can go through these steps, can I find out how your child is doing? Because the child came in with a condition. The child came in with tonsillitis and we gave them the wrong medication. How are they doing? Where is your child now? Okay, if it was a medication that was given in error, what is a common one? Penicillin allergy, and you have given amoxicillin. You want to find out adverse effects of that. Are they coughing? Do they look short of breath? Okay, do they look lethargic? Is there any drooling? You're thinking airway, breathing in, changes in their breathing pattern. Are they having any changes to their pitch of cry? Okay, because then that could show that they're having some form of stridor. Okay, now, did they develop a rash? Is it itchy? I'm very sorry. It's important for me to see the child. No, my child is at home. You guys tried to kill him once, I'm not bringing him back again. Then can you take him to the nearest clinic or the nearest hospital near your home? You know, it is clear that you don't want to bring him back here because you've lost your faith in us. And I'm sorry that we have done these mistakes. But can you first, before saying incident report, can you focus on this child? We've given them the wrong medication for their tonsillitis. They will still need to get the right medicine. We've given them the wrong wrong medication for their ear infection. We still have to give them something for that ear infection. Okay, you want to still find out about the allergies. How, you know, when was their first encounter with penicillin and what were the events? Were they intubated? Did they have to get a trach? Goodness, and now they are home. So you have to first focus on the child and then you can go to the inanimate things of writing down your incident reports talking to your senior doctors, reporting to the highermost authority, okay, your liaison services and what have you. People make big mistakes is because they focus first on the inanimates as opposed to the family and to the mother. That child needs to be seen. Okay, please show genuine concern about the well-being of the child. Okay, development, psychosocial and family support. Now, in a case like this where the mother is really shouting, yelling, she may take 3 minutes of your yelling. And then now you want to go into a very, very deep history of finding out how are they doing in school, how are they playing, how are they doing. If you're running out of time, you just have to focus on the presenting complaint and how to manage. Whenever you're managing an error in pediatrics, first of all, I told you, focus on the child. The child may need, let's say for the medication error, the child may need, first of all, an assessment. Let's make sure their ABC is fine. Can we treat their old infection, their tonsillitis and their ear infection? Can we give them new meds? Good. Then now can we make sure that they are not having, if they're having a rash, can we give them pain meds? Can we give them some Benadryl, anti-itch? Okay, if it's extensive, can we tell the mother, if the child is itching, to cut those nails short? Can we now also prevent that for future? Because I'm thinking, how do we prevent this from happening again? 2 ways. The mother can help us and we can help ourselves. There must be a breakdown in our policies because a child came in and was given penicillin or given amoxicillin with a known penicillin allergy. So there's a problem with our system. Can we review the nurse who gave the medicine, the doctor who prescribed it, and the pharmacy who brought the medication up? All of them to training. All of them to training. Can we make a different alert system? Maybe have some bright yellow bands that we can put on the patient's arms. Can we put their allergy right underneath their qualifying information or their demographics? James Smith, 3 years old, NHS number 12345, allergic to penicillin, rash. Can we update our computers and maybe even on the top of the chart have a sticker to say that they are going to have an allergy to penicillin? Are you going to wait for the end of the month to have a meeting? No. In report today, I am going to alert, of course, I'm going to tell my consultant about this error, and we're going to fill out the recommended reports. Sometimes you don't even have to say incident report. You don't need to. Okay, we'll fill out the appropriate adverse outcome report, incident report, or we'll fill out a report saying what happened, the effects of what has happened, and the outcome, and what we need to do to prevent this from happening again. I will talk to my colleagues during our evening report. We are going to have an annual meeting at the end of the month. Really? We're going to have an end of, it's July 7th. You're going to have a meeting on the 30th of July about this case. How many other patients are going to have problems between now and the end of July? So immediate action has to be done when errors have been made. And if you are the one who has made the error, you have to be almost on your knees. I'm not saying physically, on your knees verbally. I need to sit down, Samantha, and go through my steps of how I order medicines, where I made a mistake. I need to also look and see, was I a bit overwhelmed with my schedule that day? We have educational supervisors. I will go and sit down with my educational supervisor. He can guide me on how to prevent this from happening again. I will have a checklist to make sure before I prescribe medicines, I'm looking at the allergies and even talk to the mother just to make sure that there are no allergies. And for you, Mama Samantha, what can you do? Get your child an allergy bracelet. Start teaching your child about his allergies so that he can know, when I'm in the hospital, I have to tell the doctor, I'm allergic to penicillin. If your child can sing the whole Superman song and the Sonic the Hedgehog and do the whole dance, teach your child the right thing. Teach them how to save their own life. Teach them about their allergies. Beautiful. And then now, because it seems that his response to this allergy is getting severe, it may be good for you to have, an adrenaline in his safety box. Or can we send him to an allergist? Sometimes if a patient has already had anaphylaxis from a reaction, they may need adrenaline just in the car, just in case another crazy doctor FY2 from Kenya gives them this med. So now, what is the essence of this review? It's to show you that you have everything that you need to pass any exam. Literally, in medicine doesn't change. Even with this COVID, what different thing did we do? Well, we are putting people in isolation. Have we changed the way we listen to lung sounds? No. Have we changed our methods of intubation? No. Have we changed policies, maybe in emergency medicine to be faster, okay? And maybe introducing or equipping our staff with more knowledge on how to intubate patients, okay? Nasopharyngeal or oropharyngeal swabs, that's a thing that's done for viruses, okay? So if you really want to ask about how many cases are in the Plab, pediatrics alone 1,000 just from the blueprint. You can have a case with a child who has burns, okay? If they're telling you there's a case, a child who is not able to walk, what other developmental problem can this child have? Millions of problems. Cannot hear, they cannot see, they have astigmatism. Okay, another one is coming with immunization. Pediatrics immunizations and milestones, you will always find a case. You don't need any records. A child who can't sit still, James is coming in all the time, he's jumping here. Can you give him some medication to keep him still? Oh, your child has ADHD. Really? In 8 minutes? ADHD, you need to have the attention, hyperactivity, and inattention. So there's a deficit in attention, which is inattention. And then there's the hyperactivity component. So they can't sit still, they're hyperactive, and they want to concentrate, but they can't. And it's not only in the home, but it is in 2 or more settings. So they have to be evaluated at home, at school, and maybe in a hospital setting. Don't jump to give parents diagnosis, especially as a junior doctor. And in pediatrics, it's not safe, okay? An aggressive child. Oh, the neighbor's cat. The neighbor's cat was missing for a few days, and we found it, its tail was clipped, and I found the tail under Tommy's bed. He's aggressive, antisocial, and he has antisocial behavioral disorder, oppositional defiant disorder. Really? You need to know age groups, because antisocial disorder cannot be given to somebody who is under the age of 18. This one cannot sleep at night. Is it because you're busy playing loud music in the neighbor's house? Is he having pain? Have you given him a paper for a mattress? Is it cold? Does he share his room with Jimmy, John, James, Adam, and Isaac and Abraham? Even me, I can't sleep in that room. You're getting so freaked out asking questions like obstructive sleep apnea for a child of 3 years old. Maybe he's obese, but that's such a far differential. Okay, child with constipation, what is he eating? Okay, do we need to know his bowel patterns? A child cannot walk. So let's do this. In fact, it's 2 o'clock. Yes, we're going to get into some of these pediatric cases. It's important for you to know things like burn percentages. You need to know how to calculate these things. You need to know how to calculate, what do I have for tomorrow? Yeah, look at all these, gross motor, fine motor, speech and language. Now that you have time to study for this exam, I want you to invest in it. For those of you whose exam is August 13, of course, now it's just polishing, but at least you have a month to really engage and get into good knowledge accumulation and practice. Because it's one thing to know the cases, it's one thing to have your resources, but if you're not practicing, please. So set the fire up in your groups again. The Plab is back on track. Okay, let's start practicing. Let's start discussing some of the good cases we have in this book. Okay, and now you have other resources. Okay, I'll see you tomorrow. Let me see what questions you have. But for those of you who need to go, this video is going to be available so you can go and listen to it again. I think I've discussed so many cases just in passing. Okay, so you can add them to your wonderful notes and then expound on them. Get your Zoom meetings and start your own little Plab courses. Yes, I'm here to support you. So that is it for today. I am going to now pen off and then I can answer your questions, but I'll see you tomorrow.